Welcome to another case study. So this is a common case study. So this is a common case study. So and it reads, is a case study 12, and it reads: a woman collapsed after 30 minutes, and 30 minutes of delivering a 5 kg baby. Then what is your diagnosis? Then mention the 4 causes. Then how would you manage this patient? Then mention 4 complications of postpartum hemorrhage. Okay, so they have already given us an hint on the answer, more like they have already given us the answer in plain on the last question. So what is your diagnosis? So this is a case of PPH. Okay, this is a case of PPH, and this is a postpartum hemorrhage. Then mention the 4 causes. So the 4 causes, remember, we have a memory aid, so we call them the 40s. So these are things you are not supposed to forget. We have the torn, trauma, tissue, and thrombosis. But those are things to help you remember. So what do you mean by torn? So an example of undertone, the most common cause is, which is also the most common cause under the same PPH, is uterine atony. So that's torn, which is uterine atony. Then the other T. So we have the 40s. Let me just write here. We have the 40s. So we have done one T, which is torn. Then the other is trauma. So we did torn. Then we are now on trauma. Okay. So under trauma, we have lacerations. So vaginal tears. An example of the same trauma. Then under tissue, example under tissue is retained placental tissues. And then lastly, we have thrombosis, where we have coagulopathy. Those are some of the causes of PPH. So if you were to go in details on the causes, so on the causes, we just like try to exhaust what we mean by torn. So we said the 40s, so let's start with torn. So what do we mean by torn? So this accounts for the most cause of PPH in about 8%, with the separation of the placenta and the uterine sinuses, which are torn and cannot be compressed effectively due to an imperfect contraction and retraction of the musculature, and bleeding then continues. So in other words, this same torn, it is a serious condition that can occur after delivery, and when it occurs when the uterus fails to contract after delivery of the baby, and even leads to PPH. So you also need to know the risk factors for this same torn. So we gave an example of uterine atony. So under torn specifically, let's now talk about so I'm trying to do this. Okay, let's now talk about UT, which is uterine atony. So UA. Okay. So UA is uterine atony, which typically is the best example for torn, or is that's what we mean when we talk about torn. Then the risk factors for uterine atony, we have overdistended uterus. So overdistended uterus can occur in multiple gestation, polyhydramnios, and hemacrosomia baby. So that's overdistended uterus. Then overworked uterus can have a rapid labor, prolonged labor. Those are overworked uterus. Then it can also occur in a relaxed uterus, such as use of uterine tocolytics. So example, monk sulfate, adrenergic agonists, arofen. Those are some of the uh, cases where we end up having a relaxed uterus. And other causes, other risk factors, we can have we can have infections such as chorioamnionitis. Then finally, other factors, we can have grand para, malnutrition, and anemia. So anemia is also common. Then the other risk factor is antepartum hemorrhage, so the previa and the abruption. Then the other is a placenta incluta, then anesthesia, so depth of anesthesia, anesthetic agents lying other than arofen may cause atonicity. Then uterine defects or malformations, e.g. in uterine fibroids, also mismanaged, third stage of labor, and obesity than the previous PPH. Then also age more than 40 years. Then drugs, we also mentioned drugs such as tocolytics, mag sulfate, and other drugs as well. Okay, so when you are assessing for clinical features of uterine anatomy, you find that it's usually a dwarfy or soft uterus that can be palpated above the umbilicus, and it can be deviated off the midline. Then remember, the uterus should be below the umbilicus and firm. So that's all on uterine anatomy, and we can even go now to the next part, which is trauma. So under trauma, you have to bear with so that's the second T. So under trauma, which accounts for 20%, this is the second most common cause. And we actually talk about trauma to the genital tract, which usually occurs following operative delivery or even after spontaneous delivery. Then blood loss from the episiotomy wound is often usually underestimated, and similarly, blood loss in a cesarean section amounting about 800 to 1000 is also most often ignored. Then trauma usually involves the cervix, vagina, perineum, and but the most common, like I said, you find that they usually talk about the vaginal tears, but trauma examples can have the cervical, the vaginal, the perineum, the paraurethral region, and rarely rupture of the uterus occurs. Then the bleeding is usually revealed but can rarely be concealed, such as a vulvovaginal or broad ligament hematoma. Then, so to summarize what we have talked about lacerations, hematoma, uterine invasion. So uterine invasion can occur, and should know what kind of maneuvers to use. Then the last part we talked about is uterine rupture. So those are some of the causes under trauma, but you also need to go in detail how you classify the lacerations, the first degree, second degree, and whatnot. Those things you need to talk about. When you go to uterine invasion, you need to know the presentation, the maneuvers used to manage presentation, the uterine rupture as well. Okay, so we were talking about trauma. So we are talking about trauma, and we are even done with trauma. So let's discuss the other part, which is tissue. So under tissue, this is something to help you remember. So tissue, we usually talk about a retained placenta, so which accounts for about 10% of the causes of PPH, which is the third most common. Then risk factors for retained placenta, we can have an accessory lobe placenta, which is the most common. So of course, you have to examine the fetal and maternal side of the placenta. If there is any blood vessel going over the membrane, which is suggesting an accessory lobe in the uterus. Then the other risk factor is so it has even changed from trauma from tissue let's talk about. So we are now just talking about a retained placenta. So retained placenta. Okay, then the other risk factor for this same retained placenta is placenta attachment disorders, where we have the abnormal implantation of the placenta in the uterus, which can cause retention of the placenta after birth and heavy bleeding. So, what are the same placental attachment disorders? So, for the placental attachment disorders, uh, we usually let me just write A I P. AIP. Those are the placental attachment disorders. So we have placenta accreta. So this is the A I've written. So we have placenta accreta. So placenta accreta, this is where we have the placenta villi, which attaches directly to the myometrium rather than to the decidua basalis. Then we have the placenta increta. This is the I we have written here. So the placenta increta is when the placenta villi invade the myometrium. Then we have the placenta pecreta, where the placenta villi penetrate through the myometrium, which may invade the bladder. So in conclusion, you have to know that from what we have said, accreta, increta, and pecreta. So the same A, accreta, is also, you can also use the same A to remember. So A for attaches, then I for increta, but also remember that this one attaches to the decidual basalis, but not necessarily going beyond that, or not necessarily invading it, just attaches. And then I is invades, or the increta is equal to invades, so that's the I. So it's the placenta villi invades the myometrium. Then the last P is penetrates. So for pecreta, penetrates. So it penetrates through the myometrium and can even invade the bladder. So those are some of the things to talk about under under tissue. So we have done the 30. Let us now do the last T. So the last T is thrombosis, where we talk about coagulopathy. So these coagulopathies such as hemophilia, use of anticoagulant drugs. So we are talking about coagulopathy under the last T, which is thrombosis. So coagulopathy, okay, it's fine. So drugs, anticoagulant drugs, as well as acquired or inherited clotting factor deficiencies. So then another cause is the obstetric disseminated intravascular coagulopathies. Then in terms of risk factors for thrombosis or coagulopathies, you can have placental previa, which is the most common of DIC due to hypofibrinogenemia. Then in severe preeclampsia, example, ELP syndrome, you can even ELP syndrome. Then the other risk factor is amniotic fluid emboli. Then the other risk factor is thrombocytopenic purpura. Okay, then of course you find that others can also put then maybe other causes where they just fail to classify them, where they just say others, like unexplained hemorrhage. So unexplained hemorrhage where there is no definitive cause of the same PPH. So that's one of the difficult ones. So that's the end of the exhausting the causes. We can now go to management. So management for PPH. So of course this is an emergency. When you are called, you have to go and confirm, you see what's happening, you call for help, then you make a quick assessment, you do your ABCs, you start your fluids, you massage the uterus, you do your two large bore cannulas. You give your IV fluids. So IV fluids you can even give 2 to 3 times of what the patient has lost. Then in terms of oxytocin, you have to use the 20 international unit in 500 mils of ringers or normal saline at 40 drops per minute. Then you go on to do your blood for FBC, cross match, and bedside clotting time. Remember, I'm not doing this alone, so of course it's happening. Everyone is doing something, so then you have to after you have massaged the uterus. Remember, we started massaging the uterus because of the tone, so it's like you're assessing for uterine anatomy. Okay, and then you have to examine for any retained tissue lacerations. That's the next thing now we are doing. We are examining the for any retained tissues or lacerations. Then next thing is we are going to give misoprostol. You can even give per hospital guidelines. So I'll just give an example. You can give misoprostol 800 micrograms sublingual or per rectal if needed. The next thing is tranexamic acid 1 gram IV over 1 gram IV over. You can even repeat after 30 minutes. So that's the tranexamic acid, which is an antifibrinolytic, which prevents breakdown of clots. Then after, if the patient is still bleeding, so the other thing I forgot to mention was after you massage the uterus, you have done your fluids, your oxytocin. If the patient is still bleeding, you have examined the the perineum. If you have checked for any retained tissue, if you have given misoprostol. If the patient is still bleeding, you give a tranexamic acid and everything I just have mentioned. And if the patient is still bleeding again, you can do your bimanual uterine compression. If the patient again is still bleeding, aortic compression, which reduce blood supply to the uterus, at least, especially in skinny patients. Then if still bleeding, can do a balloon tamponade. So specifically you can even do a condom tamponade, especially in our setups, so where we push in inside the uterus and push in normal saline. Okay, then if the patient is still bleeding, then definitely then you have to take to theater, where you can go and do your X-lap. You do your bleeding suture, your uterine artery ligation, or if all these things nothing is working, then sadly you can even go up to the subtotal hysterectomy. So it's a very sad case if you're just going. So this is our last option, the hysterectomy. Okay, so we've exhausted most of the data on the PPH in terms of management. So that was the management we are talking about. Okay, then of course other things you have not on the quick assessment. You have to exhaust a lot of them. Then mention 4 complications of PPH. So complications we are now on complications. So under complications we can have acute blood loss, which may lead in shock and death. We can have a chronic blood loss, which may result in iron deficiency anemia. Then in the long run, the patient might even develop Sheehan syndrome. We can also have we can even put hysterectomy as a complication, though I don't really like to put it, but it's one of the complications. So when you ask, at least you have to put it there. Then the other is, since we talked over blood loss, we have mentioned shock, so you can even exhaust this kind of complications. And the other complications might come in, especially if you've identified the cause. But the ones I've mentioned are general, so it's fine even if you put them on what we have just discussed. We discussed just now. So I think we have covered most of the things we were supposed to discuss here, and we've come to the end of the case study. So this is the longest case study we have done for PPH. So I thought of, instead of just answering the question, at least I exhaust a lot of things. So, but this, I was just exhausting depending on the question that were asked. But you definitely have to go through this case study nicely. And thank you for watching. And if you haven't subscribed, subscribe to the channel and hit the bell notification. And see you on the next tutorial.